had some opportunity for some rest and rejuvenation over the holidays, and 2021 is off to a great start for you. So our speakers for this morning, I'm going to introduce the first presenter, Dr. Dhenuka Radhakrishnan, or Dana as she is fondly known to us, is a pediatric respirologist and clinician investigator with a master's degree in clinical epidemiology from the University of Toronto. She was appointed to the Department of Pediatrics at Western University in London, Ontario in 2010, and we were very fortunate to have her join us at CHEO and University of Ottawa in 2015. Dana is the director of the CHEO asthma program and is active in the development of national guidelines, as well as the Ontario Lung Health Foundation workshops and continuing education seminars on the diagnosis and management of childhood asthma. Her research involves the use of big data to investigate the incidence, risk factors, and outcomes of children with asthma and other respiratory diseases. Dana will be joined by a second presenter, Ivan Terekhov, and she will introduce Ivan at the appropriate point in the presentation. The title of their presentation this morning is Introducing the CHEO RI Data Warehouse, a resource for research and innovation. And I'm personally looking very forward to hearing this presentation. Please join me in welcoming Dana. Over to you.
Thanks very much, Mona. So I'm just going to share my screen here, and I hope this all works out. Let's see. Bear with me a moment. Let's try that again. So hopefully we're on slide 1 here. I hope you can all see that. And I'm going to minimize my thumbnail views. Mona, can I just double check that you can hear me okay and see the first screen here?
Yes, we can hear you and we can see the screen. Perfect.
Perfect. Well, thanks for joining in, everyone. It's my pleasure to present Grand Rounds for you this morning. And as Mona introduced, the title of this talk today is called Introducing the CHEO RI Data Warehouse, a resource for research and innovation. And I will be joined by my co-presenter a little bit later on in the presentation. His name is Ivan Terekhov, and I think he has his camera open so you can see his beautiful face there. Ivan is the lead data architect for the CHEO RI Data Warehouse as part of the Health Information Technology program in our research institute. And he really is my right-hand man. I'm doing all the talking, but he's done most of the work behind today's presentation. So moving right along, our objectives for today, I'm hopeful that by the end of this session, all of you listening along will be able to describe the types of data accessible in the CHEO RI Data Warehouse, identify where the CHEO RI Data Warehouse can help clinical care and research, and finally, develop ideas for research, evaluation, and quality improvement projects using our data warehouse. So many of you may recognize this slide, this image that I've borrowed from the newest CHEO RI strategic plan that was unveiled to all of us at the end of December. And in this strategic plan, one of the main strategic directions reads as follows: integrate technology to streamline communications, work processes, and facilitate research using digital means. And this, of course, is music to my ears to be given such prominence that we need to amplify our ability to do research using electronic resources. And of course, imperative to this is having increased accessibility of data sets. And that, in a nutshell, is what we're going to be focusing and talking about today. So let's take a step back for a moment and think about what is data. There are multiple definitions that one could come across, and a couple of that I've found are the following: characteristics or information that are collected through observation, or a set of values for qualitative or quantitative variables about one or more persons or objects. So these are really broad definitions, but in our healthcare setting, perhaps we could categorize data as falling into the clinical sphere, perhaps health administration, and of course, research. But data unto itself is not enough. The context and quality is extremely important, of course, as well. Now, this term, data science, you may start hearing about it if you haven't already. I mean, This is a phrase that's been around probably for the last decade, if not longer. But I've only really become aware of this concept in the last 6 months, to be honest with all of you. And data science refers to an interdisciplinary field that uses scientific methods, processes, algorithms, and systems to extract knowledge and insights from structured and unstructured data. And again, that's really what we're going to be talking about today. So how do we use data at CHEO? Well, if you think about the clinical sphere, when we see a patient, we take a history, we perform a physical examination, there may be laboratory tests that we interpret, imaging that we have a look at, and all of this information or data we use to make diagnoses and to make treatment decisions. In the administrative realm, we may look at things like emergency department and inpatient volumes, PPE dashboards, nurse staffing, physician billing, and all of this data to make administrative decisions, where and how to spend money, and how to allocate resources. As far as quality, we may look at things like nosocomial infections, satisfaction surveys, hopefully not too many, but perhaps complaints, wait times, all of this to evaluate and improve the quality of care we provide. And in the research realm, the type of data we can access and use to answer questions is vast, but might include things like questionnaire responses, specialized measurements, and patient-reported outcomes. So what then is a data warehouse? Well, simply stated, it's a central repository of information or data that can be analyzed to make more informed decisions. You may be familiar with ICES, formerly called the Institute for Clinical Evaluative Sciences. This is one example of a data warehouse, fairly well known in the province of Ontario, an extremely powerful and large data warehouse that we can use for administrative purposes and for research. But we have this fancy dancy EMR called EPIC that we all love. It holds vast amounts of data as well, relevant to our clinical institution, to CHEO. Can we not use it as a data warehouse? And the answer is yes, as long as its data elements can be organized in an accessible and functional way. And here I'm going to pass it over to Ivan to talk to you about our CHEO RI data warehouse.
Thanks, Dana. So we're all familiar with these screens, right? These are the data elements and what they look like when you're doing your clinical work. On the next picture, you'll see what it looks like under the hood. So EPIC is actually built using a real-time database called Cache. And what that really means is it's very good at having a lot of people in the system at the same time, doing clinical work, pulling up information from patient charts, but it's not very good at actually large-scale data analysis. And if you've ever ran like a reporting workbench report and it took forever, you'll know what I mean. So how do we fix this? Every night we do a process called ETL, which is the next slide. And that stands for extract, transform, and load. So we take all of the data within EPIC and then we copy it down into a relational database called Clarity. Clarity is on the next slide, looks like a big jumbled mess. There's tens of thousands of tables. You essentially have to be an expert in it to actually make sense of any of the data. So while all of the data from EPIC is there, it's not very usable or user-friendly. Like our wonderful reporting team has spent a lot of time training and using it, but it's very hard to actually pull data out. It takes a long time. So we have to do another ETL process and rearrange the data into something called a dimensional data model. So we take everything that happens in the system and look at it from a transactional level. So things that happen, medication orders, ED visits, referrals are all organized into fact tables. And then things that give context to that transaction are then organized into dimension tables. So who the patient was, who the provider was, what the department was. So this actually really boils the database down to only maybe a couple hundred tables. And so that makes it very, very accessible, and we can actually use this data a lot more effectively. So the whole data flow looks kind of like this. You don't have to know any of these names, but essentially what it boils down to is the real-time data gets transformed into a relational database and then a dimensional data model, and that's called Caboodle. So Caboodle is our data warehouse, and what it actually lets us do is take non-Epic data and put it and merge it with our Epic data. So in our system, we took all our historical diagnosis codes from WinRx, from Med 2020, which is where the coders work, and we matched it up to our historical ED visits and admissions data in Epic. So we actually have data all the way back to the start of ICD-10 for diagnosis for ED visits and admissions. So we can't talk about all of this without mentioning like the history of how we implemented Epic at CHEO. So we've been a customer since 1994. Most people don't know that for the actual scheduling and registration part, but we only really started outpatient functionality in 2013. We also did labs. And as we move forward in time, we added more and more functionality. We had that big go live in 2017. And so what this means is the further back you go, the more the data changes, the less data is available, but closer to present day, we have a lot of very rich data to work with. So the overall data landscape kind of looks like this, right? And this, there's a CHEONet section on CHEONet called the CHEO Research Data Warehouse that I encourage you to check out. And it actually has this picture as well as a little data dictionary to give you kind of an example of some of the data elements we can pull. But now I'm going to hand it over to Dana to show you how we were able to help her with her project.
Thank you, Ivan. So as you're listening to Ivan, it's all a bit complicated. Thank goodness we have people like him and the rest of our Epic reporting team to organize all of this into something usable for we clinicians and researchers. But you may be thinking, okay, that's great, but how is it really useful to me at all? Well, let's think about a clinical question, something like, how many kids will have a sepsis event at CHEO in the year 2021? Wouldn't it be great if that number were 0, but chances are it won't be. But how do we figure this out? Well, we could have someone stand in the front of the ICU and count patients as they get admitted into the unit and use this information to forecast what happens tomorrow. Or we could look back in time and identify how many kids came into the unit last year, perhaps asking decision support, now our Epic reporting team, to provide us a report based on health administrative data. Or if you wanted to identify additional clinical information about these patients who got admitted for sepsis, so what is their immunization status? What medications were they on? We might hire an eager summer student to go down to, I used to lovingly refer to medical records as the dungeon, down into the dungeon to perform a good old chart review. Or could we come into the new age and use the data warehouse and bring those poor students and all of us out into the sunlight? So I'm going to tell you about how we did just that using a data warehouse, our data warehouse, to answer a clinical question. So specifically to determine the efficacy of an education intervention for preventing repeat acute care visits in children with asthma. So a little bit of background about this topic, first of all. Asthma is the most common chronic disease in childhood. It leads to high rates of hospitalization and emergency department visits, with 25% representing repeat ED visits. Ontario Health, formerly called Health Quality Ontario, released a set of asthma quality standards in September 2020. And these standards boldly state that all people with asthma should receive self-management education. Now, this is not news. We've known this for a long time. Asthma education is a cornerstone of treatment. And with this in mind, the CHEO Asthma program that was launched in April 2018, in fact, provides comprehensive asthma education for all children admitted to our hospital for an asthma exacerbation. Interestingly, there haven't really been many real-world assessments of the effectiveness of asthma education for preventing repeat acute care visits amongst this type of patient population, children who have been hospitalized for asthma. So that is what we set out to do. to compare the risk of repeat asthma-related acute care visits among children who received comprehensive asthma education to a matched cohort of children who did not receive education. Secondly, we aim to determine the feasibility of developing an encounter-based asthma patient database that captures all inpatient and outpatient visits to CHEO for asthma and includes information on various patient-level characteristics that we might use in future research. So if you've provided inpatient care at CHEO, you may know that since April 2018, every time a child is admitted to hospital, an order set is generated. There's an asthma care pathway on our inpatient side, and automatically a trigger is sent or an order is generated for scheduling comprehensive asthma education for that patient. One of these three lovely people, these are our certified asthma educators at CHEO. We have Andrea Higginson, Mark Tessier, and Serena Lowe. I'm going to grab my handy dandy pointer. Andrea, Mark, Serena. They receive this order and schedule an asthma education session for the patient and family. And what we aim to do, we first recruited patients who had been hospitalized, electronically recruited. We didn't actually approach the patients one by one, but from April 2018 to April 2019. And we observed these patients over a 12-month time frame for our outcomes of interest, either a repeat emergency department visit or a hospital admission. And that comprised our education cohort. We then compared these children, or aimed to compare these children, to a retrospective cohort of children who had been admitted starting from April 2017, so 1 year earlier, prior to the launch of our asthma education program. So all kids admitted for asthma were identified over a 1 year span and followed for a subsequent 12 months for the outcomes of repeat emergency department visit or hospital admission. And this data was gathered through the help of our decision support team. And I have a picture here of Madhura Tipsy, who's our asthma program and research coordinator. So drum roll, please, our results. Well, it so happens in our pre-education cohort, so April 2017 to 2018, there were about 202 patients hospitalized for asthma, and this number excludes patients who were already followed in the respirology clinic. And the reason for that is our respirology patients comprise a special subgroup of asthma patients, and what happens to them may not be relevant to your average admitted child for asthma. 23 of those patients, so 10% of them, had a repeat hospital admission within the year following their first index hospital admission for asthma. Post-launch of our asthma education program, in that year, there were about 216 patients admitted for asthma with the respirology patients excluded, and only 11 of them, so 4.8%, came back to hospital for a repeat admission. So this is great news, a 53% reduction in repeat asthma admissions, and I will take that as a success on behalf of our team and everyone who's helped us with the launch of the program. But only some of these 260 patients, in fact, received asthma education. There may have been other reasons, due to the day that they came into hospital at times, and whether or not the family decided to come back for an asthma education session or participated in it at all. And sometimes we had no-shows, for example. So we were really interested in the effect of our intervention, our comprehensive asthma education delivered by our asthma experts, our certified educators. How does that impact repeat acute care visits for asthma? So in order to answer that question, we performed a time to event analysis. So we looked at the time to first readmission following hospital discharge amongst children who received. So children who received education is the green line here, or children who did not receive, which is the red line. Asthma education. Was there a question? All right, so these two cohorts are age and sex matched, and only the green line only includes children who received asthma education. Now we get a sense that there's a separation of the cohorts. The green line generally is below the red line, which is good news for us for the duration of the observation period, except once we get towards the end of the about a year. But confidence limits are overlapping, and that's why these red and green shaded areas are overlapping here. except for within the first 3 months. So perhaps we could say that our intervention provided a delay to readmission of in the range of 3 months. How about emergency room visits? We also performed a time to event analysis here, looking at time to the first emergency department visit following the asthma hospital discharge amongst children who received, again, the green line, or did not receive red line asthma education. And again, these are age and sex match cohorts. And the reason why they're age and sex match is that's the information that was readily available to us when we use this specific data source, which is our administrative data at CHEO through decision support. And in this instance, we see really no difference between the cohorts at all. These lines are crossing and twisting and overlapping each other completely. So our intervention didn't seem to change the rate of emergency department visits following discharge. So when we looked at this, somehow it didn't quite sit well with us. You know, I mean, we of course feel like we're doing a good job and we must have prevented something. In fact, the literature does consistently show asthma education to be of benefit in terms of preventing morbidity, even mortality, in fact, amongst people with asthma. So we thought about a little bit and wondered, well, did we really have the right comparison cohort? Because who are the kids who received asthma education from our program in 2018? Because as mentioned, some people actually declined to participate. And the kids who received education, are they necessarily the same as all of the kids who were admitted to asthma in 2017? You know, perhaps if asthma education were offered in 2017, would there have been some patients who declined to participate? But we've included them in our comparison here. There may be differences between cohorts that we just didn't measure in terms of adherence to treatments that were prescribed following admission, maybe their socioeconomic status, maybe the things that trigger their asthma, their allergic status, for example. So could there be a better way to match these cohorts? And the answer is yes, if we had more granular and more fulsome data available for these patients. So thankfully, this question arose just at the time of the launch of the data warehouse, which was in January of last year, in fact. And we were lucky enough to be selected as a project, as a test case, really, to see how useful a data warehouse could be for answering this kind of question. So we approached Ivan and Jeff, and at that time, it was actually Eric Benchamal who was leading the project. And requested some data, and you'll recognize this slide that Ivan had presented, which is what we as clinicians might see on the front end when we're entering in patient information. And then Ivan and his team extract, transform, and load the data into a format that's usable for us as researchers. So all this data is input to a CHEO RI project-specific database. And this database is accessible only to the research team. So it's not available in EPIC. There's no concern about breach of privacy or confidentiality. Everything is password protected with very strict access requirements. But the research team can access it. If you happen to be involving the CRU biostatisticians to perform analysis, they would have access to this project database as well. So this is what our project database looks like. Now, isn't that beautiful? I think this is such a pretty picture, but maybe I'm just a data geek. But just to boil down, there's lots of fine print here. What I wanted to point out to you is that we have much more fulsome data about our patients now. We have information about their comorbidities, information about their allergies, their PRAM score when they come into the emergency room, how severe their respiratory distress was, their lab values, and in the setting of asthma patients, this could include pulmonary function test results, measurements such as their weight, height, oxygen saturation, and in even their medications. So this is gold. We then approached our friendly neighborhood CRU biostatisticians, and for all the CRU listeners, you will of course recognize Nick and Vid. They are if I call Ivan my right-hand man, Nick and Vid are my left-hand people, because without them, none of this could be put together. It requires really experts to think about how best to analyze the data. And what our CRU experts came up with was to perform something called Mahalanobis distance matching technique. So a type of multi-dimensional matching to achieve better balance between the cohorts. And we then repeated the time to event analysis. So this is a snapshot of our patient cohorts. We have the pre-education cohort here. Our education cohort only includes those patients who truly received our comprehensive asthma education. And if you look on the right hand, we have some p-values comparing the two cohorts, and we see there are some differences between them in some of the characteristics that we measured. For example, the proportion of children who are Ontario residents versus Quebec residents was different. The proportion who had allergies documented, the proportion who had a primary care provider listed in their medical chart. And of course, these factors may influence the risk of repeat acute care visits in the future. And this is what we saw with our more rigorously matched cohorts. Time to first readmission following hospital discharge. Again, the green line represents children who received asthma education, and the red represents children in the historical cohort, matched historical cohort, who did not receive asthma education. Now, we don't see anything very different than what we had done before when we simply perform an age and sex matched analysis. And this is just to refresh our memories. This is what the time to event graph looked like for hospitalization following index hospital admission for asthma. And really, these two graphs look very, very similar. So our more robust matching techniques with all this additional data from the data warehouse didn't necessarily show much of a difference here. But to me, this was really interesting. So this is the time to first emergency department after the asthma hospital discharge. And I hope you're seeing the same as me, but this green line is clearly separated and below the red line. Yes, our confidence limits are still overlapping, so this is not a statistically significant difference, but we do get a sense that there may be a separation of cohorts here, that there may be some benefit to asthma education, if I might be so bold as to suggest this is what we're seeing. And what we thought is, maybe with an increased sample size, we would see even more separation of these cohorts. And this is just to refresh our memory, what the curve looked like before, where the lines were really almost completely overlapping. And the picture here is very different. So to summarize that all up, what did we learn? Well, from a clinical side, I still certainly believe that asthma education at CHEO may be effective. And in fact, when we had done just a crude analysis comparing numbers in the 2017 cohort compared to 2018, we saw this 50% reduction in asthma rehospitalization. Perhaps if we increase our sample size with our more rigorous matching, we might see this borne out as far as statistical significance as well. But we've actually used this information. So using the additional information we could get from our more rigorous analysis using the data warehouse, we've now added in an additional step in our asthma program to book a refresher asthma education session sometime between 1 to 3 months after the first one, and hope that this could provide additional benefit to our patients as far as repeat acute care visits. But what else did we learn as far as the context of this talk? Well, this is certainly a proof of concept that the data warehouse can be used to answer clinical research questions and perhaps answer them better, allowing for more rigorous analysis. We now have a cohort of children with asthma that we can follow over time. And over time, we can add more cohorts and even more data. For example, we can link in publicly available data sets such as the Air Quality Index in Ontario and measures of socioeconomic status. And these are future directions for this project. So how long did all of this take? Well, we received the green light as far as being selected as a test case for this project in March of 2020, and the analysis was completed by December 2020. It was extremely inexpensive, so it didn't really cost too much. Certainly there's human hours involved, but I'll show you how inexpensive towards the end of the presentation. And the punchline is that all of this happened during COVID. So just to emphasize how accessible this data is and this type of research can be to all of us, despite what might be going on in the setting of a pandemic or anything else that comes our way. So if you're like me and you're interested in asthma, that was a super interesting study to learn about. But perhaps your areas of interest are elsewhere. So what else could we study with this type of data? We have a little dreamer here, and what is he thinking about? Well, maybe we're interested going back to that idea of sepsis. How many spot calls happened at CHEO or in general over time? What are these spot calls for? What are the associated factors in patients who have a spot call? Maybe we're interested in CF and patients with CF liver disease and their health outcomes. Maybe we're interested in surgical assessment, outcomes of conservative versus surgical management of acute appendicitis. Or maybe we're in the rare disease business and we're interested to identify patients with rare diseases more easily using our vast data in our data warehouse. And I showed you one type of analysis using data from the data warehouse, time to event, and some rigorous matching. But can we do anything else fancy with this type of information? How about predictive modeling? Can we employ machine learning? How about artificial intelligence? Well, Epic already has an artificial intelligent machine learning algorithms built in its systems that are available to us. In fact, the version of Epic that we have at our hospital, we need simply to, and I put simply in quotations, it's not exactly simple, but very accessible to us to turn on a switch, so to speak, and employ a sepsis algorithm that we would be able to identify children with sepsis or who are developing sepsis early at our center. And we're actually quite interested to move forward with this project. And all we're looking for is a set of eager and interested clinical champions, people who are interested in sepsis or perhaps care for children with sepsis, as this is a project we'd really like to see move forward in this year. So if this is an area of interest for you, please contact me or Ivan, and we'd love to assemble a team and get this project started. But I want to switch ideas for a moment and let you know about another project that has just started using our data warehouse. This project is spearheaded by the Department of Genetics, Sarah Sawyer, Kim Boycott, and Caitlin Chisholm in partnership with our data warehouse team. And the title of the project is Think Rare, using data science and artificial intelligence to identify patients with undiagnosed rare genetic disease. So the premise of this project is that rare genetic diseases affect up to 400,000 Ontarians, mostly children, and can have devastating impacts on health and well-being. But making an accurate diagnosis is challenging, though this forms the cornerstone of informed and best care for these patients. Diagnosis can feel like an odyssey for families and can take 3 to 5 visits to specialists over 3 to 6 years, in some cases still not yield an answer. So how do we identify patients who would benefit from genome-wide sequencing as a method to diagnose rare genetic disease, but do this much earlier in the diagnostic journey? Perhaps we can use data to develop a strategy. Clinical-wide genome sequencing offers an opportunity to provide an accurate diagnosis for rare disease in 40 to 60% of patients who meet testing criteria. And testing criteria refers to provincial criteria that have been developed to sort of use genome-wide sequencing most effectively in the right patients, and are the criteria used to, I believe, allow funding for this type of testing. But our current diagnostic strategy relies on appropriate referral, and the genetic testing often occurs late in the diagnostic pathway. So can we more quickly identify these children and offer the testing sooner? So what we propose to do is develop an innovative artificial intelligence tool that would search the CHEO RI Data Warehouse and identify patients who may be eligible for genome-wide screening but have not been seen by genetics. More specifically, the steps in this project would be to first develop a search algorithm to identify patients who had met the provincial eligibility criteria for genome-wide sequencing. And we propose to do this using the 140,000 unique patients who had visited CHEO in the years 2017 to 2019. We will then optimize the search algorithm to identify patients who would be appropriate to refer to genetics. And this would be done using some machine learning techniques to exploit patterns that would connect the EMR data in our EPIC data warehouse and provincial eligibility criteria. And then we could assess the performance of this more optimized algorithm through new age electronic chart review. And finally, we hope to demonstrate the utility of the algorithm to truly identify new patients who are eligible for testing. And this would be done by deploying the optimized algorithm within our data warehouse and identify active patients who had been seen at least once in the year 2020. And if these patients, whoever is identified as meeting criteria, we would contact, or the genetics group, more specifically would contact the most responsible physician and offer to see these patients in the rapid access genomics clinic. And ideally, if all of this works with reasonable accuracy and reliability, we would propose to automate this process, perhaps sometime in the future, such that our data warehouse is being scanned continuously to identify patients meeting these criteria. Based on prevalence data, it's estimated that there are about 100 children who are seen at our hospital every year who would benefit from clinical genome-wide sequencing, but these children have not yet been referred to genetics. So you could just imagine if we could harness this kind of AI technology using the data in our data warehouse, what a powerful impact this could have on real patients who we see at our hospital, ending their diagnostic journey and hopefully improving their life and their quality of life. And shifting now topics slightly again to the emergency department, I wanted to give you yet another example of how our data warehouse is currently being used to improve care and the quality of care we provide. This project is titled Forecasting CHEO Emergency Department Visits Early, Often, and Accurately, a Predictive Model Approach. This project is a collaboration between Richard Webster and Deepthi Reddy at the CRU and some heavy hitters within our emergency department, Mala Butt, Ken Farian, Sandy C., and Roger Zemek. The aims of this project are to build and validate a predictive model of CHEO emergency department volumes, and then to determine the accuracy of the ED volume forecasting based on this predictive model. So what is the premise of this project? So this is a beautiful figure prepared by Richard Webster that is meant to show the amount of variability in the day-to-day volumes that we see in our emergency department. I'll point out that the y-axis on this figure shows us the months of the year, and the x-axis shows us ED volumes in terms of number of patients coming in the door. And each of these squiggly figures is an aggregated histogram of the daily visit count for each of these months. Now, what's cool about this figure, and to highlight the concept of this amount of variability, is that the date in the title keeps shifting. And it starts from 2014 and moves to 2019. And what we can generally see is that over time, these squiggly figures shift to the right, indicating that emergency department volumes are increasing at CHEO. But this increase is not linear. There's quite a bit of variability as represented by the squiggles in each of these figures. This figure here, also prepared by Richard, is another representation of a similar concept, but this time providing us with not an aggregated view, but a time series view. This time being on the x-axis and patient volumes being on the y-axis. And again, the date in the title of this figure is changing to indicate that year to year, there is a change in patient volumes that we're seeing, in fact, an increase over time. And again, this increase is not linear, and there's a huge amount of variability. But in this figure, we can make out some patterns. In general, we are seeing that there's low visit volumes in the summer months, June, July, August, and higher visit volumes, perhaps we could say, in our winter seasons. So what is contributing to this variability? Can we pattern it? Can we model it? Hopefully the answer is yes. What Richard and the eMERGE team have come up with in terms of predictors or variables that may be influencing the variation in eMERGE visit volumes. These predictors could include things like weather. Is it a rainy day? Is it very hot and humid? Is it very icy and snowy? And there have been accidents, for example, on the road, and that's influencing the eMERGE volumes. What type of day are we talking? Not just the day of the week, but is it a weekday? Is it a statutory holiday? Or is it summer vacation? And does that influence our emergency room volumes? And then we know that there are temporal patterns to certain diseases. For example, we call it respiratory season for a reason. There is a cyclical annual variation in respiratory emergency room visits, respiratory related eMERGE visits each year. And so the hope is to pull all of this information in combination with what's in our data warehouse as far as patient visits, diagnoses, labs, etc., and come up with some predictive modeling such that we would be able to have an idea each day what is likely to come in through the emergency room door. Such information, one could conceive in the future, would be informative for planning in the eMERGE. Perhaps staffing, equipment requirements would be better allocated. This type of information might help staff at the beginning of our shift of mentally prepare for what they're about to see. But ultimately, what we hope is that we can use this kind of information to make data-driven changes to improve care, improve quality, and performance metrics at our institution. And over time, this kind of methodology could be translated to other settings within our hospital to improve care overall. So those are some exciting projects, exciting to my mind. I hope you feel the same way as me. But if we take a step back again and regroup and get back to what we were talking about, and it's the data and our data warehouse. And maybe some of you are familiar with the concept of data warehouse even prior to me speaking with you today. And you're wondering, well, how does our CHEO data warehouse compare to others that are out there? Does SickKids have a data warehouse? How about the Ottawa Hospital? And I've alluded to ICES a couple of times. Don't they have this really powerful data warehouse? Isn't that what you told us, Dana? So, how does CHEO compare? Well, as far as SickKids, indeed, they are developing their own data warehouse. That's a project that they started, I believe, even before they implemented Epic. So this is an interesting scenario where our hospital, CHEO, in fact, is a few years ahead of SickKids. And we can thank Ivan and Eric Benchamal for their foresight and pushing forward our center for moving and using Epic's solution for developing a data warehouse at our center. So our data warehouse is developed, ready to go, and already being used to analyze information and answer clinical questions. The Ottawa Hospital indeed has a data warehouse that they developed several years ago, again, prior to implementing Epic. But this doesn't necessarily restrict us. I mean, there's still opportunities for collaboration and syncing up data in future if we want to do translational projects following, individuals from potentially birth all the way through into adulthood. So lots of opportunities there. And how about ICES? Why does Dana keep talking about this? Well, you may or may not know that I'm an ICES scientist. And as we've developed our data warehouse and I see the power that it has and how rich this data source is, I find myself starting to ask the question, which data source should I be going to, our CHEO data warehouse or to ICES to answer clinical questions and research questions that I have? And maybe some of you have been or will start thinking along the same lines as me. So I wanted to present to you a comparison of the ICES data bases or data warehouse and our Caboodle or our CHEO RI data warehouse, just to show you the differences between the two. So as I mentioned, the ICES data warehouse includes all health administrative data in the province of Ontario, hundreds of data sets for the entire population. We're 14.5 million people or so. Absolutely incredible power to answer clinical and research questions. And there's also a number of clinical databases that have been linked up with the health administrative data, both longitudinally, continually being linked, and also on a project by project basis. But our CHEO Data Warehouse, yes, it's restricted to CHEO only, but we have the benefit of having the clinical data already available. We don't have to do any linking or matching. And this provides us quite a bit of granularity and a very rich data source. So I see that as a benefit. In order to initiate an ICES project, there are a number of hoops to jump, and this is because of the very strict privacy legislation around ICES, which is considered to be a prescribed entity. There's REB, of course, to fulfill. You have to link up with an ICES scientist. There's a number of forms to fill and a privacy impact assessment that has to happen to ensure that there will be no breaches of confidentiality. If you're planning to link up data, then there's a bit of a rigorous process for developing data sharing agreements and contracts to allow all of this to happen. So the time to get data, sometimes if you're lucky, it might be weeks. More often we're looking at months, and in some cases, even years, depending on the type of data sets that you're interested to work with. Whereas for us to use our CHEO data warehouse, yes, we need REB approval, absolutely. But after that, it's as simple as completing a sleek request form and then having an intake meeting with our data warehouse team to identify your project specifics. So you could have data at your fingertips in days to weeks within your request. The cost of using ICES data, depending again on the type of data sets you want to access, can be quite high, and this is because of all the processes that are required and all the people, human resources that are involved in getting the project going. And ultimately, often we are reliant on an ICES analyst to perform the work for us. In comparison, I believe the relative cost of using our data warehouse, though we are still using human resources, it is significantly lower. And as mentioned, I have nothing against ICES. I mean, it is the basis of my career. The people who work there are lovely, fantastic, brilliant. But it can feel at times a bit anonymous to interact, especially with ICES Central, which is located in Toronto, and our interactions are really only through email. Whereas using the data warehouse allows for a local and friendly experience, as our analysts are located in the very same place that we all work. So all that to say, from my perspective, we are sitting on a gold mine. We have this incredibly powerful tool for improving research and clinical care at our hospital, and opportunities abound for leveraging our data to develop and apply new techniques, machine learning algorithms, and artificial intelligence to answer important clinical questions. And requesting data, as mentioned, is very easy. It simply involves completing the Start Smart form. So here's a little plug for the RI having introduced this new form as recently as about a week ago, I believe, for all new projects. This is a requirement for us to complete this form, and it basically pulls us through all the steps required to conduct a research project at CHEO, from REB to data procurement, to perhaps CRU consult, contracts, et cetera, et cetera. If you complete the Start Smart form and you are interested in requesting data from the data warehouse, it will pull you to the data request form, which is very simple and quick to complete. And this data request form will then trigger a meeting with our data warehouse team. So you had the pleasure of hearing and perhaps seeing Ivan presenting some of the slides today. And this is Jeff, who is our data warehouse analyst. These individuals will meet with you, identify the scope of your project, what specific data requirements there are, and determine whether we can pull the data from Epic or not. And they will then make this data available to you on the project database, as I had explained earlier. Excuse me, and this database is available to the research team and can be linked with additional study-specific data if you have collected this outside of the Epic environment. So does all of this cost anything? I alluded to cost earlier. We are planning to provide some limited support for all CHEO investigators to access data through the data warehouse. Depending on your research team, that data may be analyzed within your team, or perhaps you are seeking to go through the CRU to perform your analysis, and we're planning for a partnership between the data warehouse and CRU to best serve the needs of our researcher investigator population. But certainly if we're talking about more complex data linking and complex analysis, I'll speak on behalf of the CRU, we would probably require some grant funding to cover costs for our team, but we are very interested to participate with you in putting together these grants and completing portions of the grant request that would involve explaining what the data warehouse is and what we can do with what we have available to us at CHEO, because we're interested in, of course, enabling all of us to be as successful as possible in using these tools. So what's next? Well, I have a picture of a wishing well here, and I want to challenge all of you to think about your clinical work, the quality of care you provide, and your research, and think about how could this electronic data improve what you do every day. And if you had your wish, what other types of data would you want access to? And then I want you to tell us about it. I'd love to hear from you, your project ideas and other data sets that you'd be interested in pulling into our data warehouse, because we are here to serve you. This is intended to be a project that grows over time to optimize all of our research and our clinical work. If you want to learn a little more, I'll let you know that coming soon, we will be organizing some health information technology workshops, hopefully in the months of February and March. We want to talk a little bit more about the data warehouse, building a project together. Hopefully we'll have an opportunity to talk about machine learning, artificial intelligence, and you'll have a chance to meet our interdisciplinary evolving data science team. You've already had a chance to meet Ivan. I introduced you by photo to Jeff. Richard Webster provided slides for the emergency department forecasting project that we talked about today, and here's his photo here. And then we also have newer additions to our research institute, Nicholas Mitsakakis, who's an expert in machine learning and artificial intelligence, and Khaled El-Imam, who's also part of the computer science department, who is also an expert in artificial intelligence, machine learning, and synthetic data. And with that, I'll summarize. So what did we talk about today? We talked about data, the types that we have and use at CHEO. And Ivan explained to you the workings of the CHEO RI Data Warehouse. I shared with you some examples of impactful research using the data warehouse, how to access it, and I've left you with a challenge to think about your own clinical work, your own research, and how this tool may be useful to you. And with that, I'd like to acknowledge our data warehouse team, the Health Information Technology Program, and our Evolving Data Science team, the CHEO Asthma Program, and the Genetics and Emergency Department research teams who shared their slides and allowed me to share their projects with you today. And I'm happy to answer any questions.
Okay. Thank you, Dana. That was a wonderful presentation. You absolutely described the CHEO Data Warehouse so well. You highlighted with a really great example of your own experience with your asthma education study. And then you brought in some new study examples for us to think about as well. I think this is a very exciting direction for us at CHEO and beyond. So thank you so much for a great presentation, and to Ivan as well for all your expertise and your participation in this presentation as well. So we have about 5 minutes for questions or comments. We have a really good participant list today. So please either raise your hand or start talking or let me know.
I did see there's a question from, I think, Robert about asking specifically costs for trainees like residence fellows who want to use the data warehouse. So we are hopeful to be able to support certainly residents and trainees to pull data from the data warehouse. And what I'd recommend is simply complete the data request form and send it to us, and we'll meet with you. And it really depends on the complexity of the project, but our aim and our goal is to be able to support whatever types of research questions come our way. So in short, the answer hopefully is yes, that we'd be able to support that kind of request.
Mona, it's Jason. Can you hear me?
Oh, yes, go ahead, Jason. Yeah, thank you.
Thanks very much. So I just want to take this opportunity to congratulate Dana and Ivan on a fantastic presentation and overview of the data warehouse, and to also congratulate Dana, Ivan, and Jeff on their leadership of this work and carrying on the work that Dana had mentioned Eric had started a couple of years ago. I think this really is a tremendous resource. I think Dana's shown us how it's been used thus far, and provided sort of some tantalizing tips on that hopefully will have people thinking about how they can access the data warehouse for their own projects. With that in mind, Dana, I wanted to ask, what do you think the capacity is? If you get a deluge now of requests, what's the capacity of the data warehouse team to be able to address these?
So that's a great question, Jason. The very quick answer, I don't really know. It kind of depends, because what we're looking at, I mean, we have the data available, and the data extraction sometimes is complex. Sometimes it can be very simple and straightforward and not really take more than, let's throw it out there, 10 hours, for example, for our expert analysts to pull and extract this data because it's organized so nicely. And then we're really talking about the analysis portion. And there we're reliant on either the team within the CRU to provide that support for investigators, or perhaps a research team has their own support to perform analysis, for example. So it kind of depends. And I know that's not a great answer to the question, but as far as simple data extraction, I think we could do hundreds of projects, but it really depends on the complexity and what we're looking at. If we're looking to link external data sets, that may take more time. So we'll kind of have to see. As we get requests, we will develop a triaging system, and we will be our aim is to be very transparent with investigators and talk about to what extent we're able to support projects or not, and work with investigators to find novel ways for funding if we run into that sort of issue.
And
thanks for that.
Just...
And as you highlighted, I just want to, oh, sorry, Ivan.
Sorry, I just wanted to add that, yeah, like Dana said, it really depends on the type of data that you're looking for. So a lot of the projects coming to us right now are kind of that traditional, you're looking at unstructured data, notes, things like that. That's not really the angle that we're trying to go for. I think projects like Richard's or the genetics projects from Sarah that are looking at discrete data elements over large periods of time. I think those are the kind of the best projects that utilize the data warehouse in the most effective manner.
Thank you for that. And as Dana highlighted, this is a pillar of our new strategic plan for research for CHEO. And with that in mind, the RI is prepared to put resources behind this. And so as capacity grows and interest grows, we look forward to being able to continue to support this effort and grow the team and our ability to support this type of work.
Great. And I certainly hear from you, Dana and Ivan, that a key part of all this is that initial consultation to make sure that you have the right plan for your study, and that this is really the right approach. And it's not, once you've done your grant and everything, then you come and talk to us. It really is an important part of that initial consultation.
Absolutely, Mona. Thanks for bringing that up. As mentioned, we'd like to be involved in your project from the ground up. So if you have an interesting idea, don't hesitate to come talk to us or submit a data request form, and we can help you develop it.
I don't see any other questions, but I just wanted to make one other point that, I'm so impressed with the timelines and if you have the right project and you set it up properly, the timelines are just so attractive. And it seems to me that it's also really well suited because of that to learner projects who are here for a short period of time. And I'm wondering if you have any plans to do similar discussion or programming with residents and fellows.
That's an excellent idea. Thank you for bringing it up. I mean, we, for now, perhaps had a bit of tunnel vision, focusing on the research community within the RI, but Mona, that's an excellent suggestion, and I'd be happy to chat with Rasheen or Toby and talk about an opportunity to discuss this resource with the residents for sure. That'd be great.
Okay, fantastic. So I think everyone, there's lots of very positive comments and kudos in the chat that everyone can see. I think everyone else is thinking about what their project might be. They're going to meet your challenge, Dana.
Yeah.
And I think they will be reaching out to you with lots of questions. I think Jason's right, there is going to be a deluge. So congratulations to you and the team. And thank you so much for an excellent presentation.
Thanks, everyone.
Bye-bye.